Evening. This is Dr. Garais, BIO116 and/or BIO117. And let's see. Today's lecture is on chapter 21, water and electrolytes. Now, we already know that the positive, like anything that are ions, are reactive. So positive ions are cations like sodium, potassium, and calcium here. And of course, hydrogen ion. And hydroxide and chloride are anions. We forgot about magnesium here. Right, so they're reactive, they're reactive ions, but they're dissolved in water, hence the term electrolytes. And homeostasis requires a balance of not only the water or the solvent that it's in, but the solute, which are sometimes are in salt form, which are these electrolytes. Body fluids are not uniformly distributed. They're in different volumes depending on different pressures, and we're going to talk about those pressures and situations momentarily. Since female patients normally have more adipose tissue, they have relatively less water than their male patient counterparts. 52% versus 63%, and this is based on the population in general. 40 liters of water, give or take, and the two major compartments we're thinking about is intracellular fluid, which is the fluid inside the cells, and extracellular fluid, which is the fluid outside the cells. The majority of the fluid is in intracellular fluid, more than half, about 63%. So think of it this way, all the chemical processes have to be done inside the cell or intracellular. So it would make more sense that there's more fluid in the inside than the outside. Now, intracellular fluid, of course, everything inside the cell, but extracellular fluid, I want you to think of these four things. And I kind of put transcellular fluid in like a separate category, but it is part of your extracellular fluid. Interstitial fluid, of course, within the tissue spaces, blood plasma, of course, in blood vessels, and lymph, which is just like blood plasma, same composition without the plasma proteins, and those are in lymphatic vessels. Transcellular fluid, which is part of extracellular fluid, is kind of like a little side note, because these extracellular fluids, they're kind of sequestered, meaning that they're in their own little spot, and they don't really react too much or to the outside world, because they have highly specific functions. For example, the cerebrospinal fluid is major communication fluid in your central nervous system. It means your brain and spinal cord. Aqueous and vitreous humor have their function, which is, of course, light refraction, and that is in the eye. Synovial fluid is function for synovial joints and freely movable joints, your diarthrotic joints. Those are for lubrication and reduction of friction upon movement. And the serous fluid, again, reduction of friction in between the visceral and parietal serosal layers and serosal coverings of our heart, our GI system, and our lungs, to name a few. So think of transcellular fluid as like kind of like a little separate side note, but it is part of the extracellular fluid. So you can see here intracellular fluid, extracellular fluid, and the interstitial fluid, plasma, lymph, and transcellular all are part of extracellular. Extracellular fluids also have sodium, chloride, calcium, and bicarbonate. Intracellular fluids, potassium, magnesium, phosphates, and sulfates. I prefer to remember the extracellular fluids because they're the more common ones: sodium, chloride, calcium, and bicarbonate. Now, the way fluid moves in and out of things. Well, there's two pressures, the hydrostatic and the osmotic. Now, the hydrostatic pressure has to be equal and stable within the cells and interstitial fluid. It shouldn't change too much. It's the osmotic pressure that changes. Now, remember osmoles or tonicity, you know, how much salt or how much solute, which are the electrolytes, are in something. That dictates where fluid goes. Remember, we keep on saying in class, wherever salt is, water will go, right? Wherever salt goes, water goes. And that's kind of how you should look at osmotic pressure, because they deal with impermeable solutes, stuff like sodium, chloride. Next. This is a lovely picture because it lays out several things and several concepts. For example, the concept of going in and out of your capillary walls. It's definitely due to osmotic pressure. So for example, if there's tons of sodium, way too much more, and I think I figured out how to use the pen. If there's way too much sodium increase here inside my plasma, of course, through osmosis, because remember your plasma wall is a semi-permeable membrane. So of course, right, there's a lot of sodium, we also just learned in the respiratory, let's say that there's a ton of oxygen inside the plasma. Then everything's going to go out because this will be in a greater concentration, this will be a lesser concentration. And the rules of osmosis is things move from a greater concentration to a lesser concentration, and that's dictated also through osmotic pressure. We have pressure to go where? Out. Now, let's say, for example, I have a lot of carbon dioxide buildup here in my interstitial fluid. CO2. It's a lot more than what's inside my plasma, right? Because let's say, for example, my cells start kicking out CO2 because they're doing a lot of processes. Then if it's greater CO2 in the interstitial fluid, then it should go where? It's going to go in. And we kind of learned that in the alveoli, if you recall that. We kind of learned that in the alveoli, you know, going in and out of the capillaries in your lungs. And the same thing from your capillaries into the rest of the organs in your systems. So that's osmotic pressure, right? And I know they mentioned hydrostatic pressure here, but the hydrostatic pressure is it remains stable. It's the osmotic pressure that's, you know, increasing and decreasing depending on the concentration of said item. Like here, oxygen and sodium, and here, carbon dioxide. Now, remember transcellular fluid? Stuff can go in and out, but it's usually what? Sequestered. So things don't really move too much in transcellular fluid. Now, lymphatic, the natural pressure or the natural gradient is from interstitial fluid to lymph. But let's say, for example, lymph isn't doing its job. It's broken or we removed it. What's going to happen to all the fluid? It's going to back up into your interstitial fluid, and then that's when you get edema. How long it takes me to write it. Wunderbar. Okay. So let me go back to laser pointer mode. So these are the major movements, right? You have osmotic pressure, a dictating movement of ions or solutes in and out, in and out of the interstitial fluid and in and out of the plasma. And if anything happens to my lymph, right, or it starts backing up, remember there's valves, it's relatively low pressure, then if it can't do its job, edema starts backing up into interstitial fluid, and that's not a good thing. Water intake, of course, their center, water output by kidneys, that makes sense. Water intake is usually from drinking fluids, and then a distant second is moist foods, and then you have water metabolism. But number one water intake is fluid, and you should be averaging 2.5 liters per day. How many of you are drinking 2.5 liters per day? I'm lucky if I drink 250 cc's a day versus 2,500. But that's how much you should be drinking. So maybe the bros in the gym got it right when they carry their jugs of mystery fluid that they're always bringing into the gym. How about water output? Number one, urine. A little bit from the feces, but of course, I got diarrhea. This will increase drastically. You have sensible perspiration, which is the sweat that you can feel, but you have a decent amount of loss in insensible perspiration, which is evaporation from your skin. You could pause this. This is a nice video right here, and then graphic, right? Water from drinks, okay, and some moist food. You should have what, 2.5 liters a day. And if I'm taking in 2.5, I should be getting rid of 2.5. Remember, water balance, and the majority of water is lost in urine. Thirst, primary regular water intake. Your osmoreceptors in your brain look at extracellular fluid, yeah, we kind of know this on how the RAA system gets activated. And of course, where are osmoreceptors? They're big on homeostasis, so they're obviously in the hypothalamus. ADH, we already know, anti-diuretic hormone. So of course you're dehydrated or you're walking in the desert, it will stimulate ADH, and your ADH will make you keep the water and keep the salt. Okay, that's what we're doing. Conserve water. And then of course, if you drink too much, the exact opposite happens. Electrolyte balance, electrolyte intake. The majority of your electrolytes are excreted in the urine, and they're also mainly obtained from food. Okay, so you eat electrolytes. So, and it's the same thing with vitamins or any chemicals. It's better just to derive them from food. And of course, they get removed from your kidneys and slash urine. You kind of know that. This is a little bit more simplified. And remember the number one, urine, a little bit of feces, and a little bit of perspiration. This we glossed over in class because in theory you should know, but since it's a video, I might as well review it. You know that parathyroid hormone comes from your parathyroid gland. It is vital and integral to calcium maintenance in your body. And we know that calcium is a big time ion that turns things on, especially with the heart. So you have your plasma concentration, the calcium ion concentration decreases. So of course, parathyroid gland gets stimulated, releases parathyroid hormone, and it has 3 actions. First, it's going to tell your intestines to keep as much calcium as it possibly can. Then it's going to tell your bone to start doing bone resorption. Bone resorption requires increased osteoclasts. If you recall, last term, osteoclasts are the bone cells that break down bone so that phosphate ions get released. And phosphate ions, once they get released, that also releases calcium ions. And last but not least, the parathyroid hormone will tell the renal tubules to save as much calcium ion or reabsorb as much calcium ion as possible. So you have your intestines, you have your bone, and you have your kidneys doing stuff in response to parathyroid hormone. Okay. Oh, got to mention potassium. So what happens if I got too much potassium? We know that calcium is the cation ion that turns things on. Potassium, we already know, is the cation ion that turns things off. Remember the depolarization of your heart and the T wave in your EKG. Potassium ion concentration increases, so we want to get rid of it. So what do we have to do? Remember the sodium potassium ATPase pump? Hint, hint. We're about to see it in action. Adrenal cortex secretes aldosterone. Makes sense. Why are my adrenals right next to my kidneys? Because it's part of the RAA system. So once your adrenals release aldosterone, renal tubules increase resorption of sodium ions. If I take in sodium, I have to get rid of potassium. Remember the loop of Henle, the sodium potassium ATPase pump? So that's what happens there. So sodium ions are conserved, potassium ions are what? Secreted out into the urine, and hence dropping your plasma potassium ion concentration, which is the function of this process here. Great, my mouse is cooperating. Acid bases, acid balance, we already know. pH, I don't think we have to go over that. Physiologic pH is 7.35 to 7.45 or 7.4, which is like in the middle. The main basis of acid-base balance is through the hydrogen ion. Examples of a strong acid, hydrochloric. Example of a weak acid is carbonic acid. That's the one where we combine water and carbon dioxide and it makes carbonic acid. An example of a strong base is sodium hydroxide. Example of a weak base is the buffer sodium bicarbonate, NaHC. Now, all this regulation can happen three ways. One, through a chemical buffer system like bicarbonate, or respiratory excretion of carbon dioxide. We already know that when we exercise, and also if my patient is a little bit acidotic, what are they going to do? They're going to breathe faster. They're going to kick out CO2 while they're breathing, because CO2 and H plus are kind of linked together. And last but not least, renal excretion. We saw how your kidneys can either keep or throw out things. Well, if you're acidotic, your kidneys will start to kick out or start to secrete hydrogen ions to bring back your pH to a respectable level. Bicarbonate buffer system, we already talked about that. It's a weak base. So if my patient is acidotic, the bicarbonate gets released and brings you back to the middle. The phosphate buffer system is the exact opposite. Dihydrogen phosphate, right, is considered a weak acid. So if my patient is alkalotic, phosphate buffer system kicks in and then slowly brings you back to pH of 7.4. Protein buffer systems, it can be an albumin. I might have to change my practice questions. I only thought it was in hemoglobin. All right. So I guess it's into plasma proteins because hemoglobin definitely can pick up hydrogen ion. I did not know that albumin can do the same thing. So let's look out for that particular question. It's a little bit different. Hemoglobin, of course, buffers H plus by H plus can sit and hang out in the hemoglobin. And then if I take out the H plus in the system, that's going to lower the acidity or the acidity level in my blood. And that's your protein buffer system. But number one, think what? Hemoglobin, number one. Respiratory center, of course, there is we already know the respiratory centers in our brain. they, especially the central chemoreceptors, they focus on CO2 and H plus. Nice, but I don't like these. Renal. Oh, okay. I lost it for a minute. Nephrons, of course, they're the microscopic functional units of the kidneys located in your cortical region of your kidney. And they help regulate because remember the reabsorption and secretion process. So if in the proximal and distal convoluted tubules, so if I have way too many H pluses, I can do what? Secrete out H pluses and bring my pH back to normal. And that's the renal excretion process. Or process, but it's another word is compensation, because your body compensates for if it's acidotic or alkalotic. Of course, pH below 7.35, acidemia, pH above 7.45, alkalemia or alkalosis. And we looked at here is the range 6.8 to 8, that's survival range. So like 6, 9, 7 is very acidotic for human being. 7, 8, 7, 9, that's very alkaline. Remember, acidosis has a lot of H pluses. Remember, on this side, pH is closer to 1 here. So this side has a lot of, what happened to my pen? Hold up. Pen. Okay. Let's see why my pen isn't working. Working a minute ago. Okay. Well, going back to here, let me bring it back. Maybe is the highlighter, the pen. Okay, there it is. Sorry about that. So on this side, of course, my patient has a lot of hydrogen. On the other side, alkalosis, my patient has a lot of hydroxide. Either situation is not a good situation to be, because I need to be where? I need to be in the middle. So OH minus, H plus. And that's what, and that's how we kind of look at acid-base balance. And the body likes to concentrate. The body likes to concentrate getting rid of this. If I'm too acidotic, I'm going to try to get rid of this. If I'm too alkalotic, I'm going to try to keep this, offset this. Respiratory acidosis, that means my patient has acidosis, they're acidotic, and the reason is due to some respiratory problem. The respiratory problem could be sourced in the brain. It could be something like obstruction, like COPD, or anything that hinders gas exchange, so any lower respiratory tract infection. Metabolic acidosis, of course, I want you to think number 1, diabetes, and diabetic ketoacidosis. It's number 1. When they have uncontrolled diabetes mellitus and then eat whatever they want, they have no diet, they're not on any good meds, and they get acidotic really fast. And of course, kidney disease, because if your kidney isn't working, it's not throwing out H pluses, you're going to have increased acid. Respiratory alkalosis, of course, due to think that your patient is most common is anxiety. And if they're breathing really fast, it's going to kick out CO2 and they're going to be alkaline. Metabolic alkalosis, number 1 is vomiting. You throw out a whole bunch of gastric acids because you're vomiting too much, like in hyperemesis gravidarum our patients, and also hyperemesis states on patients who are going through chemotherapy for cancer. They can go into metabolic alkalosis. Compensations, chemical buffers, we already talked about that. And, oh, that's it. Quickly as it came, it went. So thank you very much, and I'll see you guys in class.